Welcome back, ladies and gentlemen, to the YourGoToDoc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon for over 25 years, and today we're going to talk about 6 spots in your body that can fool you and your doctor into thinking you have a low back spine problem, when in actuality you do not. So we're going to go over what those things are. I'm not going to go over in too much detail about each individual issue, because that could be an entire video in and of itself. So we're going to just talk very superficially about those 5 or 6 things that can cause trouble, that can trick you into thinking you've got a low back problem. And this is going to be important for you to sort of keep in the back of your mind to make sure that you and your doctors don't start barking up the wrong tree. So let's get to it. 6 spots in your body that can fool you and your doctor into thinking you have a low back problem. So before we start talking about all these things that can fool you into thinking you have a low back problem, let's first talk about what the typical patient with a low back problem looks like. And this will help us figure out how the other things I'm going to talk about are different. So when you have a lumbar spine problem, typically you're going to have back pain. But associated with that, if a nerve is being bothered, you're going to have symptoms going down to lower parts of your body. One side of your lower back, the buttock region, the groin, the hip, the thigh, the lower leg, the foot, pain, numbness, tingling, and weakness. So those are the kind of symptoms you're looking for when a lumbar spine nerve bothers you or is giving you trouble. Typically, if you are getting symptoms down your leg, it's going to be the same side as the nerve that's being pinched. There's no crossover like in upper parts of the body and the brain. The pain from a pinched nerve is typically going to be a toothache-like pain. It's going to be a deep, gnawing, moderately severe pain that can interfere with what you're thinking and doing. It can incapacitate you. Typically, a patient who's got a pinched nerve in their back will come into my office, and when I ask them to show me where it hurts, they'll put one hand on one side of their lower back, and then they'll run it down their leg in a distribution following that particular nerve that's being pinched. And included in that hand running down to the leg is usually the butt cheek. Typically, patients with pinched nerves in their low back are going to have buttock pain. And this is different than some of the other things we're going to talk about. The symptoms from a pinched nerve in the back are often exacerbated when you move your back around, because whatever spot that's kind of rubbing on that nerve is going to rub more. And also, it'll typically hurt more when you stretch that nerve. And that's something in the exam room in my office we would call a straight leg raise positive test. And basically, you're lying on your back. I keep your leg straight, hold it by the ankle or the heel, and then lift your leg up, and that will stretch some of the nerves in your low back that go down your leg and exacerbate your pain if it's a pinched nerve in your back. Historically, a pinched nerve in the back will often be associated with some type of incident. The patient will remember, I lifted a bunch of laundry and put it into the washing machine, I cut down a tree, I coughed. Something like that, where they remember I was fine before the incident and then afterwards I was not. And then these patients in the office or exam room, they often can't sit still when the nerve is bothering them. They're kind of shifting around all the time. And that's different than other things that can fool you into thinking you have a pinched nerve in your back. And then lastly, and most importantly, the symptoms that the patient describe running from their back into their butt cheek down their leg will match the pattern that I would expect from what I see on the MRI. And this is crucial here. Symptoms in the back running down the leg, it could be 6 other things that we're going to talk about, but if your MRI shows a spot that matches up with that very well, really raises my confidence level that that's where it's coming from. So that kind of summarizes a pinched nerve in the back, and I'll touch on those again as we talk about the other things that can fool you into thinking it's coming from the low back. But that's kind of what a pinched nerve in the back looks like. So now let's go on to the next problem that can mimic a spine problem in your low back and a pinched nerve, and that is a sacroiliac problem. keep in mind, I've done an entire video on the sacroiliac joint and what that's all about, so you can go and look at that if you think that's what might be going on. But the first thing we'll touch on is a sacroiliac problem, which is the joint between the sacrum, or the tailbone, and the iliac bone, which is kind of the pelvic bone that you put your hands on your hips with. I'm not going to show you what that looks like, on models and things like that, and go into the surgery to fix that, because that's a whole different video, which is available on my YouTube page to look at. But let's talk about the sacroiliac joint and what that looks like to a doctor or a surgeon that's evaluating you for this problem. So what does a patient look like that has a sacroiliac problem that they wouldn't look like if they had a lumbar spine pinched nerve problem? Well, the first big difference is the patient with the lumbar spine pinched nerve problem, as I said, will put their hand on one side of their back and run it through their butt cheek down their leg. A patient with a sacroiliac problem often will take a single finger and point to a single spot in their low back region. And that spot is usually the dimple spot. If you, for whatever reason, were looking at someone's naked backside, those two dimples at the end of the lumbar spine are the tops of the sacroiliac joints, and the patient will usually point to one of those dimples and say, that's where it's hurt, or that's where it hurts, or that's where it's coming from. So that's one difference. Another difference is the patient with a sacroiliac problem usually sits differently than someone who has a pinched nerve in the back. And as opposed to shifting around all the time, they typically will lean to one side on an elbow and keep that left or right butt cheek off the chair, not to put weight on it, which is different than the shifting, constantly moving around movement of someone with a pinched nerve. On a physical exam, there are specific maneuvers that you can do on a patient's body to move the sacroiliac joint and exacerbate or reproduce that pain, different than the movements you would do to check a nerve being pinched in the low back. And those are called provocative maneuvers of the sacroiliac joint to test for that. And there are 4 or 5 of those that are easy to do. And if the patient winces in pain and says, oh, that's it, when you do one of those provocative maneuvers for the sacroiliac joint, then that will raise your suspicion it's not a pinched nerve in the back, it's their sacroiliac joint. Often on imaging, you're going to not see very much in the sacroiliac joint. The sacroiliac joint can look normal on pictures, MRIs, CAT scans, X-rays, and that doesn't mean that their sacroiliac joint is not causing their trouble. Keep in mind that even though the pain is coming from the joint between the tailbone and the hip bone kind of thing, the patient can get symptoms in the butt cheek all the way down the leg, and that's because the sciatic nerve does run by or run near the lower part of the sacroiliac joint. So patients with sacroiliac problems can also get leg pain, which again can trick you into thinking it's a pinched nerve in the back. Typically an SI or sacroiliac joint problem is not associated, or the patient can't remember a particular incident. So it's not like they lifted the laundry or cut down a tree and then their sacroiliac joint started hurting. Typically it's a more gradual process over time. This is somewhat associated, and if you look at my video on the sacroiliac joint, I go into this in more detail. But sacroiliac joint problems are more common in women, and that's because it's thought to be associated with childbirth. That joint will get loose during childbirth and sometimes not tighten back up, whereas sacroiliac joint problems in men are more often associated with trauma. So in that case, it could be they fell off a ladder, skydiving incident, whatever. So the last 2 points about the sacroiliac joint are, number one, again, this is very important. If they've got pain in their sacroiliac area, their butt cheek, their leg, and you're like, oh my, this could be a pinched nerve in the back, the kicker is you look at an MRI and the nerve that you would think would be pinched based on what they're describing, usually the L5 or S1 nerve, looks fine on the MRI. So that's a big indication that even though it sounds, looks, smells, tastes like a low back spine problem, it may not be because the MRI doesn't show a problem. And then finally, if it's coming from their sacroiliac joint and not their low back, the patient will typically have a dramatic improvement in symptoms with a CT-guided sacroiliac injection. So the radiologist puts the needle in the sacroiliac joint using a CAT scan to guide that needle in the joint, injects some numbing medicine, which usually kicks in right away pretty quickly. The patient gets off the table and they're like, oh my God, that was amazing, my pain's gone. Well, if they had a lumbar spine nerve problem, a pinched nerve in their back, that CT-guided sacroiliac injection wouldn't help at all. So that's the final kind of nail in the coffin to prove it's a sacroiliac problem. So those are some differences between a sacroiliac joint problem that can mimic a pinched nerve in the back problem and how you can kind of tell the difference. So let's go on to the next topic, which is a hip problem. Okay, so a second common problem that mimics low back pain and low back pinched nerve problems that I see in the office is a hip problem. Very, very common for a primary care doctor, a pain management doctor, a chiropractor, or even the patient themselves refer themselves or get referred to my office, and they're labeled on the schedule as low back pain or lumbar radiculopathy, which means pain down the leg from a pinched nerve in the back. And then I check them, and it turns out it's not coming from the back, it's a hip problem. So what are the differences between a pinched nerve in the back and a hip problem? Well, again, similar to what we talked about with the pinched nerve in the back and the sacroiliac joint, the patient, when I ask them where it hurts, will often point to different spots. So low back problem, hand on the one side of the back, shooting down the butt cheek and the leg. Sacroiliac problem, single finger pointing at the dimple spot in the back, and then often they'll say the groin hurts too, and maybe areas of the butt cheek, and then rarely down the leg with the sacroiliac joint. Now finally, with the hip problem, which we're talking about right now, the patient will, again, take a single finger or two and literally put it on the side of their body where they put their hands on their hips, maybe a little lower than that, and they'll point with a finger. That's where it hurts, on that side part of the hip joint. Or anatomically, they'll often point to the greater trochanteric area or greater trochanter area of the hip joint. So that's a difference there. They usually point to that spot. Hip problems will often include a lot of groin pain. So they'll take their hand and they'll run it down the crease of their groin and say, that's where it hurts too, deep inside that area. If they do get symptoms in the leg, it's typically in the front of the thigh, but above the knee. So it rarely, if ever, goes down below the knee. So they could run their hand down the front of their thigh, again, closely associated with a hip problem. In a physical exam in the office, you can isolate the hip joint with certain maneuvers, and if you twist that hip joint or put pressure on the inside of the knee to move that hip outwardly or externally rotated, you can reproduce symptoms in that hip joint. That can radiate to the groin, it can radiate to the back, but that isolated movement of the hip joint reproducing their symptoms will also suggest it's the hip, not the lumbar spine. And then when the patient describes their symptoms, they will often kind of give this classic triad of description, which is, it hurts when I lie on my side at night, the side that the hip joint is giving a trouble. It hurts when I get up from a chair, and they'll often hold their hands on the armrests and help themselves up with the chair, out of the chair. And then lastly, a lot of pain when they walk up steps. Walking up steps is kind of the third common thing. Now there are extras and variations that also you see with hip problems, but those are the three that are most common that a patient will describe when they sort of talk about why what happens when their hip hurts. Patients with hip problems usually don't sit like someone with an SI joint problem or a lumbar spine pinch nerve problem. They tend to sit very still. So that's different. Again, just like the other two things we talked about, nothing on the MRI that matches up with those symptoms. Either nothing's pinched at all on the MRI, or nothing matches up with a groin pain problem, which would be your lower sacral nerves, or a front of the thigh pain, which would be the number 3 or the number 4 nerve. So if the MRI doesn't show anything like that, and you've got all these other things that kind of fit with a hip problem, it's likely a hip problem. And then finally, similar to the sacroiliac joint, a fluoroscopy-guided hip injection that makes the symptoms feel better is a sort of the nail in the coffin that's the problem, it's your hip. Again, the radiologist or physician, orthopedic surgeon, pain doctor, whoever, they'll use an X-ray machine to guide a needle into the hip joint. Typically, to prove that they're in the hip joint, especially if they're using x-rays or a fluoroscope, they'll inject a little bit of dye into that hip joint to prove that the needle is actually in the joint, because you can be fooled on x-rays. If the dye kind of spreads into the joint space like you'd expect for it to be in the joint space, they now know the needle is in the joint space of the hip. They'll inject some numbing medicine. That kicks in right away. Maybe a little steroids, that kicks in later, and then they take the needle out and they let you go home. And then I, as the surgeon, would say, did you notice any difference? Now, sometimes the patient will come back to the office and say, yeah, I got the hip injection and it didn't help. It didn't help at all. I feel exactly the same as I did before. My hips, my side, hip, groin, leg is killing me still. But then I'll clarify and I'll say, yeah, I understand it's still hurting right now, but that was 2 weeks ago you got your hip injection. How did it feel immediately after the injection, and then for the first 24 hours after the injection? And if they say, oh yeah, then I had no pain at all for the first 24 hours after the injection, but then it all came back, that still counts as a positive injection, because that's the numbing medicine. The numbing medicine kicks in right away, but it only lasts 24 hours or so. So that window of time where the patient notices dramatic relief, same with the sacroiliac CT-guided injection, is a big proving point that it's not a pinched nerve in the back. It's coming from that particular spot that was anesthetized with the numbing medicine. I also, patients can, this is still a subjective kind of test, because we're relying on the patient to tell us that their pain was better. So sometimes to kind of make it less subjective, I like to find out before the injection, when I first see the patient, what number out of 10 is that pain? 10's the worst, 0 is no pain at all. So, the patient will say usually 7 or 8, it's hurting in that spot, whichever spot it is. And then I instruct them before the injection, as soon as you get in the parking lot after the injection, write down on a piece of paper what number out of 10 does it hurt. Every 3 or 4 hours after that, for the first 24 hours while you're awake, write down what number out of 10 it hurts. And then they come in with that piece of paper, and I see in my notes it's an 8 out of 10 before the injection, and there on their piece of paper, 0 out of 10 in the parking lot, 2 out of 10 4 hours later, 3 out of 10 2 hours later, 2 out of 10 4 hours later. So that dramatic change, 8 to 0, 8 to 2, kind of tells me it's coming from that spot. So that's kind of the difference with the hip problem versus a pinched nerve in the back. And by the way, after I get through these 6 red herrings that can fool you and your doctor into thinking you have a pinched nerve in your back problem, we're going to look at some pictures that kind of spell out where it hurts and what it looks like on the body for these different problems. So let's go on to the next topic, which is something called piriformis syndrome. So what is piriformis syndrome? Why does it sound so funny? Well, it's named after a muscle. There is a muscle in your leg called the piriformis muscle. And this muscle is a little different than the typical leg muscle. It's kind of a short, fat muscle, and you'll see this on pictures in a little bit. And it runs this way across your leg instead of up and down like most of the muscles in the leg run. So the piriformis muscle is a short, fat muscle, and it kind of assists in rotating your leg. But the reason that it can trick you or your doctor into thinking you have a spine problem in your low back or a pinched nerve in your low back is that the sciatic nerve runs under the piriformis muscle, and you'll see that on the pictures. And if that piriformis muscle gets swollen or inflamed because you did an activity that used that muscle and upset it, you can inflame and irritate the sciatic nerve. And you can get pain shooting down your leg that feels just like pinched nerve pain. So if you've got pain running down your leg from a sciatic nerve problem, how can you kind of tell that apart from a pinched nerve in your back? Well, there are a couple of tricks. Number one, the starting point of pain with piriformis syndrome is usually lower than the starting point of pain with a pinched nerve in your back. The piriformis muscle kind of is in the deep lower buttock region. And the spot that the sciatic nerve comes out from under the piriformis muscle is kind of right where the butt cheek meets the thigh. And usually there's a crease right there. So that crease spot is typically where the patients will say the pain starts and then shoots down their leg. In addition, that sciatic nerve pinched in that spot will typically give a pain that runs straight down the back of the thigh and the calf into the foot. And that fits kind of with the S1 nerve in the spine. But it doesn't fit with the L5 or the L4 or the L3 or the L2 nerve. Those tend to kind of wrap around the leg and go down a specific path down the leg as opposed to straight down the back. So if you get an MRI of the lumbar spine and the S1 nerve, which is where that pain the patient describes is coming from or is traveling, and that S1 nerve looks free as a bird on your MRI, well, that could make a light bulb go off. It's not coming from their spine, it's coming from somewhere else. And because it starts in that crease where the butt cheek and the thigh meet, and it runs down the back of the leg, it should give the treating physician, or now you, the patient, the possibility or the idea that this could be piriformis syndrome. The other interesting thing for patients with piriformis syndrome is that it almost is classically irritated by sitting on hard chairs or long drives where they're in a seated position and they're getting pressure on that spot under their leg. So if the patient says, I can't drive for more than 30 minutes without my leg starting to hurt, or you have a non-padded chair in your office or exam room and the patient can't sit on that chair, they'll go off to the very edge of the chair so the back of their butt cheek is kind of resting on the chair instead of the butt cheek thigh junction area. That is a big indicator that it's the piriformis muscle that's causing this trouble. And then finally, there is a maneuver that you can do during the physical exam that will stretch the piriformis muscle and reproduce the symptoms of piriformis syndrome, irritating that sciatic nerve. And what I'll usually do with patients is I'll have them stand up and lean against a wall. I'll have them grab their knee with both hands on the side that the symptoms are, and then I'll have them bring the knee up to their chest and opposite shoulder and stretch it towards their opposite shoulder, and that will reproduce the symptoms if it's coming from the piriformis muscle. And that is a maneuver in the physical exam that can help you figure out that it's not coming from a pinched nerve in the back. Okay, so the next problem that can mimic a pinched nerve in the back after the sacroiliac joint, the hip, and the piriformis syndrome is something called neuralgia paresthetica. And this is a pain syndrome that's coming from injury, trauma, or some problem with what's called the lateral femoral cutaneous nerve. This is a branch of the femoral nerve that usually comes out under the inguinal ligament. That inguinal ligament is kind of, if you put your hands on both hips, where your index finger is where that ligament attaches to the bone, and then it runs into the groin. And that lateral femoral cutaneous nerve can come out from under that ligament and then run down the thigh. So that typically problems at that point where it exits under the ligament or comes out from under the ligament is where that nerve gets upset. And this can be often from things like belts that are too tight, obesity with someone who has a big belly that's kind of hanging over their belt, and that spot is constantly being bothered where the nerve comes out under the ligament. It's the pain from this nerve, which is a purely sensory nerve. There's no motor involvement in the muscles, so there's no weakness that occurs from this problem, unlike a pinched nerve in the back. But that pain is typically of a burning quality, which is something the patient may say. It's a burning sensation. It is typically in the front of the thigh above the knee, similar to a hip problem. But in the hip, it's kind of straight down the thigh. In neuralgia paresthetica, it's more off to the side of the thigh. Again, the burning quality. And then in addition, the thigh can be sensitive to the touch, either from clothing or bed sheets, or just touching it lightly, brushing it with your hand can reproduce pain or cause it to hurt, whereas a pinched nerve in the spine or a hip problem typically isn't affected by touching the actual thigh. The last thing, as far as the physical exam is concerned, is you can actually kind of if you know where the spot that nerve typically comes out under the ligament, you can kind of press on that area, and if it reproduces the leg symptoms, you know it's coming from that spot and not a pinched nerve in the back. And then finally, again, if there's nothing on the MRI that matches up with symptoms running down the thigh like that, then it's probably not coming from the lumbar spine either. So that fourth issue, neuralgia paresthetica, can mimic a pinched nerve in the back, so you want to make sure you're not dealing with something like that. So let's go on to the next problem that can mimic lumbar spine problems, and that would be something called diabetic femoral neuropathy. So diabetic femoral neuropathy is very similar to neuralgia paresthetica in distribution. It runs down the thigh, but in diabetic femoral neuropathy, the symptoms are more towards the front and the inside of the thigh, whereas with neuralgia paresthetica, they're more towards the front and the outside of the thigh. This problem usually comes from patients who are diabetic, obviously, and the mechanism is not a direct pinching. It's that diabetics who don't have very good sugar control get clogging of the tiny little arteries that supply the nerve. So the nerve is literally being starved of oxygen and nutrients because the tiny little blood vessels that supply the nerve are getting clogged up because the patient's diabetes is not controlled. Another difference with diabetic femoral neuropathy from neuralgia paresthetica is that it often will include weakness. The femoral nerve itself, not just the sensory branch, is being affected by this. So typically the patient will, in addition to having pain, numbness, tingling in the thigh, will have weakness in the leg. This can include straightening the leg out, which will be the quadricep. It could include lifting the leg up straight off the exam table. That would be the iliopsoas muscle. Sometimes the numbness can go all the way down the leg to the inside of the calf. The knee reflex can get lost. Technically, you can get a femoral neuropathy from anything that's going to bother the femoral nerve, but the most common reason is diabetes. Lastly, if there's nothing on the MRI that matches that spot where the patient's describing the symptoms or the weakness, then you can rule out the lumbar spine, and it's coming from a femoral neuropathy, usually diabetes. So if you're diabetic and you know your sugars aren't controlled and you've got the symptoms that I just described, you can think about diabetic femoral neuropathy. And don't be fooled that even if there's something that doesn't look right on your MRI, be careful letting a referring doctor or surgeon chase up the lumbar spine problem before ruling out diabetic femoral neuropathy. And also keep in mind that all the things that I'm talking about here, sacroiliac problems, hip problems, piriformis syndrome, diabetic femoral neuropathy, and then what I'm going to talk about next, there typically is not a lot of associated back pain. Now, granted, sacroiliac joint problems can give you referred back pain, hip problems can give you referred back pain, and all the things I'm talking about on this video can make you walk differently, which can exacerbate back pain. But most of these are not associated with back pain as a big or primary component. So again, if your symptoms fit what I'm describing for these individual pathologies, there's nothing on the MRI that matches it. Be careful about chasing up a lumbar pinched nerve problem when these other possibilities exist. And I'm not saying you don't have a lumbar pinched nerve problem, or I'm not saying you couldn't have both, but just make sure that if your symptoms kind of fit what I'm describing, that you bring it up to your doctor if they haven't thought of it themselves, and make sure they rule them out. You can rule it out by checking your sugars and making sure they're controlled and seeing if it gets better. You can rule out the hip and the sacroiliac joint with the injections, et cetera, et cetera. So let's go on to the final of the 6 problems that can mimic a pinched nerve in the back, and that is something called a common perineal palsy. So I saved common perineal palsy for last because that is a problem in the lower leg. It's basically pinching or or compression of a nerve that wraps around the side of your knee. So that's going to be less of a likelihood of fooling someone. But the problem with common peroneal palsy is it can give you a significant weakness in your foot, something called a foot drop, which is where you can't lift your foot up. And that is almost reflexively thought of as a L5 nerve problem in the back. So don't be fooled by a drop foot, everybody automatically thinking it's coming from the back. So what are some hints that it's not coming from the back? Well, number one, you don't have back, buttock, or upper leg pain. It's all from the knee down. So that kind of hints that it's not coming from your lumbar spine. With a common peroneal palsy, you not only will get weakness in your foot going up, but weakness in everting your foot or pulling it outward or rotating it outward. You're not going to have that with an L5 nerve problem. So the common peroneal nerve is a branch that comes off the sciatic nerve from behind the knee and wraps around the outside of the leg right at the fibular head. So the fibular head is the top part of the fibular bone. And if you feel that bone on the side of your knee, there's a little groove in it, and that's where the nerve travels. And it's very superficial to the skin, and underneath it is the bone. So it's very easy to compress that nerve easily. It's not protected by a lot of muscle and stuff like that. So things that can cause that are, for example, sitting cross-legged too long, direct trauma to that area if you hit the side of your knee on something. It's a common area of a clipping injury in football. If let's say you're getting surgery for a hernia repair or some OBGYN kind of procedure, the nurses and doctors in the operating room know to pad that area. Because you're asleep, you can't tell them that your leg's getting numb or it hurts. So they're supposed to pad the fibular head to make sure you don't get a common peroneal palsy. If you go into an operation and your leg and foot are fine, and you come back out and you've got a foot drop or you've got pain and numbness from the side of your knee down, you can basically say they didn't pad my knee during the surgery. There's often a area of tenderness on the fibular head that you can press on or push on, and it'll reproduce symptoms of pain, numbness, or tingling down that leg. And then finally, again, if there's no problem on the MRI around the number 5 nerve, then your foot drop is probably not coming from that. Now, there are other reasons for a foot drop, problems with the nerve between the lumbar spine and the foot. So you could have a problem in the lumbar plexus, which is in the pelvis. You could have a problem in the thigh, where the sciatic nerve runs above the knee. But those things will not present exactly as I described for a common peroneal palsy. You'll have other symptoms with that also. And then for the common peroneal palsy, the diabetic femoral neuropathy, even the neuralgia paresthetica, you could be referred to a neurologist for something called an EMG study, which is basically, layman's terms, a nerve test. And those can sometimes be helpful in proving it's one of those things as opposed to something else. So those are the 6 ailments that someone can get that can trick them or their doctor into thinking, oh, I've got a pinched nerve in my back. So before we kind of wrap up, let's take a look at some pictures so we can kind of see in a little more detail what these are all about. And again, I just want to remind you, I'm not going to go into full video detail of each of these ailments. I've already done one for the sacroiliac joint. But if you think that this might be what is going on as opposed to a pinched nerve in your back, definitely go Googling or look for other videos on these topics from people that have more expertise in them than I do. For example, a hip problem, you might want to look at an orthopedic hip specialist's videos. Common peroneal palsy, diabetic femoral neuropathy, you may want to look at a neurology video. And then piriformis syndrome, you may want to look at a chiropractor, physiotherapist, physical therapist type video. So let's go take a look at some pictures. Before we start talking about what the pain distribution looks like for things that can mimic a pinched nerve in the low back, let's first take a look at what pain, numbness, tingling, and weakness can look like for pinched nerves in the low back. So if you look at these drawings, and charts, you can see for the L4 nerve, the L5 nerve, and the S1 nerve, which are the three most common nerves that are pinched in the low back, you can get these pain distributions. L4 is going to be more into the side and front of the thigh, the knee, and then sometimes into the shin, and I usually see some in the middle part of the calf here. L5 is more on the side of the leg, wrapping around the shin into the foot. I usually see more of the big toe in real life than this chart suggests. And S1 is kind of straight down the back of the leg, and then the heel, and then the outside of the foot into the pinky toe. I typically don't see the other toes involved in S1. Weakness of these nerves are going to lead to different weakness. L4 would be straightening out the leg at the knee. L5 would be lifting the foot up and the toe up, or walking on your heels. S1 would be pushing your foot down or walking on your toes. You'd see weakness in those muscles with a problem with these nerves. And then reflex problems would occur for L4 in the knee reflex and S1 in the ankle reflex, but L5 really doesn't have a reflex associated with it. And on the right, you can see kind of the spots where a patient would typically point to with L3, L4, L5, and S1 pain and where they fall on the legs. And they're kind of starting more on the inside of the leg, wrapping around to the back from L3 to S1. So that's kind of what nerve pinching problems look like on the body when you examine the patient or they describe their symptoms. But all of that would really be relevant if you found a spot on the MRI that showed that nerve being pinched. If you don't see that, then you got to start thinking about other things. And then always keep in mind that you might see a pinched nerve on the MRI of the lumbar spine, but you're being tricked. It's not that pinched nerve. It's coming from one of the other 6 things I mentioned. And that's where experience, physical exam, patient description of symptoms, history, all go into the art of medicine and figuring out where it's coming from. So let's take a look at the next picture dealing with a sacroiliac problem. Here we have a picture of the pain distribution for someone with a sacroiliac problem. And on the right, I put in what the S1 nerve would look like if that were pinched. And you can see it's very similar to the sacroiliac problem. The patient would not have a lot of back pain, whereas if your pinched nerve was being pinched in the back, you would have a lot of back pain. But again, similar findings to the S1 nerve. The patient will typically point to a finger in this spot here, the dimple spot. That's the top of the sacroiliac joint, the butt cheek, back of the thigh and the calf, rarely into the foot, but also groin pain. You don't see groin pain with a pinched S1 nerve. So you can see why you could be fooled into thinking, hey, you're pinching a nerve in your back. But the groin pain, the physical exam findings, reproducing the pain with provocative maneuvers of the sacroiliac joint, the lack of a pinched S1 nerve on MRI, and then finally a CT-guided injection in the sacroiliac joint, making all this feel better, would really bring home the diagnosis as an SI problem and not an S1 problem, because if you injected numbing medicine in the sacroiliac joint here, a pinched S1 nerve would not feel better. So this is kind of the difference between a sacroiliac joint problem and an S1 nerve problem. Very similar pain distributions, but you're not going to have weakness in your foot or trouble walking on your toes or a decreased ankle reflex with a sacroiliac problem either. So let's go on to the next comparison, and that would be between a pinched nerve in the back and a hip problem. So here we've got the comparison of a pinched L4 nerve on this chart on the right, and then a hip problem with the pictures on the left. So the hip problem, the patient's going to point to this spot here, the greater trochanter area. They're going to rub their hand in a circle around this area. It's going to, sometimes you can see it's less red here, meaning it doesn't hurt as much as up here, but you can get thigh pain with the hip problem, and then finally groin pain with the hip problem. Again, you're not going to have weakness in your quadricep. You're not going to have a decreased knee-jerk reflex with a hip problem like you would with an L4 problem. And then finally, the hip joint rotation, internal and external rotation of the hip joint, various provocative tests. You would not see that reproduce pain if it was a pinched L4 nerve. And then lastly, a diagnostic injection in the hip making all this feel better would not happen if you were pinching your L4 nerve. So again, you can see how this could mimic this, but with all the other information, you could narrow this down as a hip problem. And even if you had a pinched L4 nerve on your MRI, if these symptoms more matched up and the injection really helped, I would certainly get your hip evaluated before you consider operating on the L4 nerve. So now let's take a look at the next problem that can mimic a pinched nerve in the low back, which would be piriformis syndrome. So before we start looking at the comparison of the nerve root versus pain with piriformis syndrome, let me just show you a picture of why the nerve hurts with piriformis syndrome. Here's the piriformis muscle. As I described earlier, it's a short, fat muscle that goes left to right as opposed to up and down like a lot of the other muscles. And this yellow nerve is the sciatic nerve running underneath this muscle. So if the muscle's upset, swollen, irritated, inflamed for whatever reason, it can bother this nerve and give you neurological symptoms. So if we now look at that comparison, we'll see the similarity with a possible pinched S1 nerve. So here is that comparison of a pinched S1 nerve and piriformis syndrome bothering the sciatic nerve. Again, S1 goes straight down the back of the leg and then into the outside of the foot and bottom of the foot. But you can see in piriformis syndrome, you don't have any of the symptoms up here that you'd have with an S1 nerve. The S1 nerve, I can tell you from experience, the patients really describe some deep buttock pain about here. But in piriformis syndrome, it starts here where that crease is between the butt cheek and the thigh and then shoots straight down the leg. It can go all the way into the foot, like the S1 nerve, but often doesn't. And again, you can see in this case very similar to S1, but not higher up. Hurts when you sit on a hard chair, hurts with long drives, not so much so with the S1 in comparison. And then even though you could get weakness and sensation problems and reflex problems with a piriformis syndrome, not as likely as with S1, but still possible. So if the MRI doesn't show a pinched S1 nerve up here, and you've got the symptoms and historical description of symptoms that fit with a piriformis syndrome, you might want to sort of see if you can treat this before you start operating on the S1 nerve. And then I'm not going to get into the details of how you can treat this, but piriformis syndrome typically gets better with time, letting that nerve relax, anti-inflammatories, injections. However, there is actually a surgery that you can do where you cut that piriformis muscle and release it, and the nerve is now free. You really don't need that muscle to function in normal everyday life, so you can get away with cutting it. But anyway, if you want to research that more, I would kind of look for videos from orthopedic surgeon YouTube channels regarding piriformis syndrome. So now let's move on to the next comparison, and that would be for neuralgia paresthetica. Here we've got, before we look at the nerve root versus pain distribution for neuralgia paresthetica, I'm just going to show you where the nerve is upset. So here are the nerve roots that combine to form the lateral femoral cutaneous nerve. Here's the inguinal ligament attaching one part of the pelvis to the other. The nerve runs right underneath it right there, and that's why sometimes belts, tight pants, obesity, scar tissue from hernia repair can all bother this nerve in this area and give you symptoms that run into the thigh that mimic a pinched nerve in the back. But that's the spot where that nerve gets upset. And keep in mind, pressing on that area or pressure on that area in the exam room can reproduce symptoms, which again is a hint it's not coming from a pinched nerve in here. So now let's look at a comparison of the nerve root versus neuralgia paresthetica pain. So here's that picture showing where it hurts with neuralgia paresthetica, that bothering of the nerve where it comes out of the inguinal ligament here, and then an L4 nerve problem. The lateral femoral cutaneous nerve here is a purely sensory nerve, so you're not going to get weakness like you would with an L4 problem or a knee-jerk problem, reflex, with an L4 nerve problem. But you can see this patch of skin here matches this here. So if there's nothing on the MRI that suggests it's an L4 nerve problem, you don't have weakness in your quadricep, you don't have a decreased knee jerk reflex, the patient is obese, the patient wears very tight pants or belts, and they really describe a patch of pain like this, and they describe a burning quality to it, you may be dealing with meralgia paresthetica instead of an L4 nerve problem, and you could certainly work this up further with an injection in the exit site of the nerve here, a nerve test, MRIs to rule out the number 4 nerve is upset. But again, this is L4 versus meralgia paresthetica. The next thing that can fool you into thinking you've got a lumbar spine problem when it's not really a lumbar spine problem is diabetic femoral neuropathy. So even though diabetes is the most common reason for the femoral nerve to be upset like this, anything that bothers the femoral nerve deep in the thigh or in the pelvis can cause this problem. But here are the branches of the femoral nerve that control sensation that can be affected when the femoral nerve is upset, and that's going to give you symptoms in the thigh like this. Middle to inside of the thigh, inside of the calf and shin, which you can see also similar to L4. Again, even though this picture doesn't show it, when people I see in the office that have a pinched L4 nerve room, they will get symptoms inside here. The other thing that can be tough is that an L4 nerve can give you weakness in the quadricep and a decreased knee reflex. Diabetic femoral neuropathy can do the same thing, because the femoral nerve, where it's affected deep inside here, also has motor branches and reflex branches that can affect those things. So again, if your number 4 nerve looks free as a bird on the MRI, and you've got these symptoms like this, the patient's diabetic, you don't really have a lot going on in the foot, and the patient's sugars are not controlled, you should certainly consider a diabetic femoral neuropathy before you start operating on the L4 nerve. You could send the patient to a neurologist for a nerve test. That could help determine that it's a femoral neuropathy. You could do a trial of getting their sugars more tightly controlled to see if this gets better. All of those types of things before considering operating on the lumbar spine when you shouldn't be. So this is diabetic femoral neuropathy. Let's move on to the final possible red herring for spinal nerve problems, which would be the common peroneal nerve palsy. So finally, we've got the common peroneal nerve palsy that could mimic a possible L5 nerve problem. And on the left, just a quick picture to kind of show you where the common peroneal nerve comes out behind the knee, wraps around the fibular head. This is the fibular bone coming down your lower leg, and this top part is the fibular head. There's a little groove underneath the fibular head that comes very superficial to the skin on the outside of the knee. So this nerve runs in that groove, and it's very susceptible to injury right there. The common peroneal nerve problem is typically an acute problem, which means it happens relatively suddenly or quickly, as opposed to other problems in the lumbar spine or the other things we've talked about. But you can see that after it wraps around this spot, it branches into the superficial and deep branches. And you can see here the possible sensation or pain distribution very closely matches the L5 nerve. But more importantly, you might say, well, it's from the knee down. It's never going to fool anybody into thinking that they've got a pinched nerve in their back. But again, as I mentioned earlier, the problem with the common peroneal nerve palsy is that it's very likely or more likely to cause a foot drop, where you have weakness in bringing your foot and your toe up. That is often reflexively thought of as a pinched number 5 nerve in the back. And if you're not really thinking well as a diagnostician or physician, you might jump to the conclusion, oh, you've got a pinched number 5 nerve in your back, and not even consider the possibility that it's a common peroneal nerve palsy. So the things that make you think that are, number 1, nothing hurts from above the knee. The MRI shows the number 5 nerve looks fine. Not only does the patient have weakness of bringing the foot and the toe up, but they can't evert the foot, bring it outward, rotate it out. That would be a common perineal nerve problem, but not an L5 nerve problem. And then add that into possibly taking a good history from the patient, and they say, oh yes, I meditate for 2 hours a day and I sit cross-legged for 2 hours a day. Or I play football and I was clipped in my knee 2 weeks ago. That kind of thing. So again, common perineal nerve injury causing a foot drop, fooling you or your doctor into thinking you have a number 5 nerve problem from your lumbar spine. And this is the final of the 6 red herrings that can mimic a pinched nerve in the back. So in summary, just be careful. Make sure you and or your doctor, and whether that's your primary care doctor, your surgeon, think really hard about your symptoms, the history, the physical exam findings, the distribution of the pain, numbness, tingling, and weakness, and be really sure that you're not being fooled that your symptoms are coming from your lumbar spine and a pinched nerve, when in reality they're coming from a sacroiliac problem, a hip problem, piriformis syndrome, meralgia paresthetica, diabetic femoral neuropathy, or common perineal nerve palsy. All these things have qualities and characteristics that can fool you or think you or your doctor think that the symptoms are coming from your lumbar spine. So I hope this video was helpful. If you think it was worthwhile and valuable, please like my YouTube channel, subscribe to my YouTube channel, and again, don't forget, most importantly, stay healthy.